Hello, everyone, and today we're going to talk about depression and mood disorders. This is for the Psychiatric Mental Health Nurse Practitioner exam. So major depressive disorder is one of the most common psychiatric illnesses. It's primarily characterized by persistent disturbances in mood. This includes things like sleep changes, interest lost, guilt, energy decreased, cognition impaired, appetite changes, psychomotor retardation or agitation, and thoughts of harming themselves. It is an excessive, distorted degree of sadness that manifests with behavioral, affective, cognitive, and somatic symptoms. It may have a known event which kind of triggered it, or it could just occur without some sort of identified stressor. It interferes with daily functioning and goal attainment, and has complex genetic, biochemical, and environmental factors which cause it. So it can be a mixture of all of those things. So the causes of major depressive disorder, so it has a dysregulation of one or more biogenetic amine neurotransmitters. So that's dopamine, norepinephrine, or serotonin. And when we look at medications that help with major depressive disorder or depression kind of in general, we're modulating those neurotransmitters in the body. They can have cognitive and memory impairment symptoms in older adult populations, and this truly can look like dementia. It's called a pseudo dementia, but it's actually caused by the major depressive disorder instead of actual dementia, and it can be confused with dementia because of that. Clients with dementia usually have a premorbid history of slowly declining cognition. In major depressive disorder, cognition changes have a relatively acute onset and are significant when compared to premorbid functioning. So when we diagnose depression, these are some of the symptoms we just went over, but there is a mnemonic called SIG-CAPS. So that stands for sleep disturbances, interest reduction in not finding interest in things they once enjoyed, feeling guilt or self-blame, energy loss or fatigue, concentration problems, appetite changes, psychomotor changes, and thoughts about harming themselves. And when you're doing an assessment with a patient assessing for depression, you can specifically ask about these things. So, any changes in sleep, any changes in appetite. Do you find that you've lost interest in activities you once enjoyed or have low energy or difficulty concentrating? And that can really help you to identify what the symptoms are that person is currently experiencing. So in older adults, we can use things like Wellbutrin, which can help to increase energy. And in older adults, they're more likely to have difficulties with cognition and concentration when they are depressed. And in older adults, a loss of appetite is common. So we talked about that pseudo dementia. So there's a nice chart here that kind of shows the difference between actual dementia and pseudo dementia. So a pseudo dementia usually has a sudden onset, where actual dementia happens gradually over time with a slow progression, where pseudo dementia, it happens very quickly. With pseudo dementia, there is a presence of insight, and they have a tendency to emphasize the disability and really focus on like, oh, my memory isn't what it used to. And oh, I have such a hard time remembering things, because again, they're in that like state of depression. Whereas with actual dementia, they'll do things like confabulation. So that is when they forget aspects of a story. So they make them up. They don't just say, oh, I forget. And they have a tendency to diminish the disability. So again, the person with actual dementia is going to try to hide that they have dementia, right? Because nobody wants to actually acknowledge the fact that they are potentially forgetting things, right? Unless they have a pseudo dementia, right? Where it's rooted in that depression. So there is that like sadness, woe is me, the emphasis on the negative. So also with dementia, we see different symptoms during time of day. So you might have heard of like sundowning. Dementia, they're going to have a worse time at night, where pseudo dementia, there's going to be no night changes. Regular dementia, their mood is going to be average, like an average person. We'd say euthymic. With pseudo dementia, you're going to see that depressed mood. pseudo dementia, you'll see kind of frequent vegetative symptoms and a psychiatric history and a high, wanting to self-harm, where with dementia, you won't see that self-harm. They usually don't, I won't say always, but they might not have a psych history and few vegetative symptoms. So that's how we can kind of differentiate between what we're seeing. So when it comes to treatment options for major depressive disorder, we really have to look at the severity of the illness and how they are presenting. So mild to moderate illness can kind of be, we can do medication alone, we can do psychotherapy alone, we can put them together depending on the person, right? And ECT we may use if it's somebody who is elderly or they have other health conditions that they can't take medications, or if maybe they're pregnant and they don't want to take medications. When we start to see severe without psychotic features, so how you can identify this is like somebody who's had it for chronic, so over 2 years, recurrent 3 or more episodes, or a PHQ-9, which you will see more information about that at other times in this course, but greater than 20. So for this, if they have a severe major depressive disorder, they need medication. You cannot just use psychotherapy alone, right? Because there really is that neurotransmitter imbalance going on in their brain that needs to be modified. You can use medication and psychotherapy together, and you can also use ECT. When we start to see severe with psychotic features, when you see psychotic features, you always want to think about an antipsychotic, right? So we'll be medicating, could be with both an antidepressant and an antipsychotic. We can't use psychotherapy alone. This person is psychotic. You can't do therapy really with psychotic people, like intensive therapy, right? But you could use medication and psychotherapy together as like a supportive psychotherapy, and you can use ECT. So when we talk about medications, we would use these when there was a prior positive response, when they have moderate to severe symptoms or significant sleep appetite disturbances or agitation. We want to anticipate the need for maintenance therapy to use along with medications, or it might just be the patient's preference. Psychotherapy, we have to look at availability. Right now, it is very difficult to get a therapist, at least in my area, especially if you're looking for one that accepts insurance. A prior positive response, we want to look at psychological factors such as interpersonal issues and stressors, any co-occurring personality disorders, the severity of illness, the patient's preference, and, if they're pregnant or breastfeeding, because that is going to change your ability to use medications. You can still use medications, but sometimes people might not want to, and there's only certain ones you can use. So, and then we can use complementary therapies. So omega-3 fatty acids, St. John's wort, SAMe, folate, bright light therapy, acupuncture, exercise, and vitamin D. And there's sparse or limited evidence to support the benefit, but for some people, it can offer some value. You need to be careful if you're using things like SAMe or St. John's wort. These are herbal or supplements that will increase serotonin in the brain, so they can cause serotonin syndrome if you're using them along with medication. So because medications are going to augment serotonin, and then plus you have the St. John's wort and SAMe, which augments serotonin. So that is a recipe for serotonin syndrome, which we do not want. All right, so what causes major depressive disorder? So there are some theories. So the first one is the psychodynamic theory. And part of this is the object loss theory. So psychological development issues lay the foundation for depressive responses later in life. They accomplish the first stage of development, so the child is able to form relationships normally. The second stage of development, the child experiences a traumatic separation from a significant object of attachment. Loss may be related to a maternal death, illness, or emotional lack of availability, and is unexpected and overwhelmed. Depth of loss produces constellation of responses dominated by separation, anxiety, grief, mourning, and despair. The critical object loss event predisposes the child to respond in similar ways to any future losses or significant separation. So the next theory is the aggression turned inward theory. This is a psychological development issue that lays the foundation for depressive symptoms responses later in life. They accomplish the first stage of the development. So again, The child is able to form relationships normally. The second stage of development, the child experiences a loss of a significant mothering person. Again, this is very similar to the last theory that we discussed. So the loss can be real or imagined. It leads to a defense mechanism to deal with the love and anger the child feels towards the maternal figure. Instead, the anger turns inward towards the mother. It is turned inward as it is safer to be angry with oneself than the mothering figure. The anger that turns inward is rationalized as the child assumes the loss of the mother is related to something bad they did rather than the caregiver's actions. This leads to excessive guilt. In adults, it leads to low self-esteem, excessive guilt, inability to cope with anger, self-destructive impulses wherever a loss is experienced. Then we have the cognitive theory. So this is a stress model in which developmental experiences sensitize a person to respond to stressful life events in a depressive manner. Cognitive theory assumes that people with a tendency to be depressed think about the world differently than non-depressed people, and that depressed people often are more negative and believe that bad things are going to happen to them because of their own personal shortcomings and inadequacies. This thinking promotes low self-esteem and benefits that the person deserves to have bad things happen to him or her. It promotes pessimistic perceptions about the world at large and about his or her future, as well as globalizing the negativity to all events, situations, and people in his or her life. When confronted by stressful events, these people tend to appraise them and the potential consequences in a negative, hopeless manner, and therefore are more depressed than people with different cognitive styles. Then there is a learned hopelessness theory. This theory is a modified aspect of the cognitive theory, which assumes that a person becomes depressed due to perceptions of lack of control over life events and experiences. These perceptions are learned over time, especially as the person perceives others seeing him or her as adequate. Perceptions of lack of control lead to the person not adapting or coping, and the person's behavior becomes passive and non-reactive because of self-perceptions of personal characteristics of being helpless, hopeless, and powerless. So then we have some biological theories. So the first one is genetic predisposition. So one can assume that polygenetic single nucleotide polymorphism disorder, having a depressed parent, is the single strongest predictor of depression. The earlier the age of onset for major depressive disorder, the more severe symptoms, the more likely it is that the person has a strong genetic predisposition for depression. Then there is the idea of endocrine dysfunction. So major depressive disorder has symptoms that suggest endocrine abnormalities as part of the etiology of major depressive disorder. Neurovegetative symptoms common seen in major depressive disorder are related to functions of the hypothalamus and pituitary and the hormones they secrete. A high incidence of postpartum mood disturbances is suggestive of the endocrine dysfunction. Dysphoria is often triggered by changes in the levels of sex steroids that occur during the menstrual cycle. Deregulation of the hypothalamic pituitary adrenal axis, you'll also hear this called the HPA axis, which controls the physiological response to stress and consists of interconnected feedback pathways between the hypothalamus, pituitary gland, and adrenal glands, is another theory of the endocrine basis for major depressive disorder. In this theory, the major depressive disorder is presumed to be, at least in part, a result of the abnormal responses related to HPA dysregulation. So in HPA dysregulation, a response to stress, the hypothalamus releases corticotropin hormone, which then stimulates the pituitary to release adrenocorticohormone, which then stimulates the pituitary. Then this stimulates the adrenals to release cortisol. Hyperactivity of the HPA has been shown to be present in people with major depressive disorder, as have possible elevated cortisol levels. Over time, the elevated cortisol level damages the central nervous system by altering neurotransmission and electrical signal conduction. Evidence supports that cortisol over time can cause changes in size and function of brain tissue, and evidence supports that major depression may be associated with pro-inflammatory cytokine activity. HPA dysregulation is the rationale and scientific basis for dexamethasone suppression test, a screening test for depression, which has proven to be too nonspecific and is not commonly used in clinical practice. Then there's also the idea of abnormalities of neurotransmitter function, so dysregulation of one or more biogenetic amine neurotransmitters, dopamine, serotonin, norepinephrine. Low levels of endogenous catecholamines in specific areas of the brain. Serotonin levels were shown to be low in postmortem studies of people who committed self-harm acts that led to their death, and in people with major depressive disorder. Low level of precursor tryptophan, low levels of serotonin metabolite, 5-HT, I think that's supposed to be 2A, if I'm being honest. I think that got written weird because 5-HT2A is serotonin. There's 5-HT1A and 2A. They're both serotonin. Receptor sensitivity for neurotransmitters set unusually high in specific areas of the brain. A stronger neurotransmitter receptor cascade is required to induce neuronal activity. A low density of receptor sites in specific areas of the brain. Hypometabolism in specific areas of the brain regulate mood, appetite, and cognition. And complexity of brain function implies that etiology of complex disorders such as major depression involves the relative balance of available neurotransmitters and not just low level of one neurotransmitter. And then structural brain changes. So some neuroimaging has shown consistent abnormalities in certain areas of the brain with chronic and severe depression, such as hypovolemic in the hippocampus and a hypovolemic prefrontal cortex and limbic striatal region. Major depressive disorder is a commonly comorbid in those who have experienced brain damage, including damage from a stroke or trauma. All right, so the next theory is the chronico-biological theory, and this is desynchronization of circadian rhythms produce symptoms of constellation collectively called major depressive disorder. Circadian rhythms control biological processes that are frequent problems in depressed person. This includes things like interrupted sleep-wake cycle, abnormalities, frequent waking, intense dreams, diurnal variations to circadian-related behaviors, decreased arousal and energy levels, decreased activity patterns, and increased cortisol secretions. So the incidence and demographics of major depressive disorder is 5% of the US population 18 and older, or over 15 million people a year. It is a leading cause of disability in the United States and the most common psychiatric illness that is treated in primary care practices. And only 50% of people with major depressive disorder ever receive treatment. It can occur at any age, but the average age of onset is mid-20s. During the reproductive year, the lifetime risk of major depressive disorder varies by gender. It's 25% of women and 12% of men. The risk is equal for the genders before puberty and after menopause. Greater sources of morbidity for women than other diseases, has a high mortality rate. 15% of people will die by harming themselves. It can involve isolated episodes separated by many years, or clusters of episodes, or a severe episode and chronic episodes. If untreated, it can last for 4 months or longer. It does occur as a chronic recurrent illness. And after 1 year after initial diagnosis, 40% of people have significant enough symptoms to meet the full DSM-5 criteria for major depression. 20% do not meet that criteria any longer, and 40% have no symptoms. The number of prior episodes predicts the likelihood of future episodes, and people with first episode depression are approximately a 60% risk for second episode, and people who have a second episode have a 70% risk of a third episode, and those who experienced a third episode have a 90% risk of having a fourth episode. So risk factors: genes, prior episodes of major depressive disorder, female gender, postpartum period, medical comorbidities, single marital status, and significant environmental stressors, including especially multiple losses. So for prevention and screening, we want to provide at-risk family education, community education to reduce stigma, screening efforts to recognize, intervene, and initiate treatment, provide healthcare, provider education, and significant and protracted prodromal symptoms periods usually noted before the full onset of symptoms. So our assessment, we should have a baseline screening with one of our screening tools for depression. So this could be that PHQ-9, Edinburgh Postnatal Depression Scale, Beck's Depression Scale, or a Hamilton Depression Rating Scale. And we want to repeat these throughout treatment to see how the symptoms are improving. So when we talk about the PHQ-9, you're going to also see this other places in the course, but you can see an example of it over on the right, just what it looks like, and then you can see what the ratings are for this. Some tips to remember, the scores for this are in the Scales and Erickson's lecture that we have. So we're just going to kind of look at what they look like and then the scales in this lecture. We're not going to spend too much time on it. Edinburgh Postnatal Depression Scale, so you can see again what it looks like and how it is scored. Beck's Depression Scale, again, you can see what it looks like and how it is scored. For the exam, you are going to want to remember the moderate scores, and for most of these, if it is lower, it is more mild, and if it is higher, it is severe, unless it is screening for usually cognitive or like Alzheimer's and things like that. And we'll go more through that in the Scales and Erickson lecture, but just keep that in mind. And then the Hamilton Depression Rating Scale, again, this is what it looks like. This is how it is scaled. Okay, so again, here are some more rating scales that can be used to screen depression or mood changes. I think all of these are depression. Okay, yes. So just some more. And just you can also see how they're rated, the cutoff scores. So for assessment, just like any other mental illness when we are assessing, right? We're getting a detailed history of the illness, time frame, progression of disease, social history, where do they live, what's their education, what is their spirituality, what's their marital status, drug use, alcohol use, what medications they take, history of medical illness or surgery. If we can, we want to validate with a family member and gain collateral. Look at their pain, look at their sleep disturbance. We want to look at history because, again, there could be that prodromal episode that consists of a high level of subjective anxiety and mild depression symptoms that develops over a few days to weeks before the full depressive episode occurs. And women often report symptoms occurring in a fixed pattern several days before the onset of menses. So we want to assess menstrual history as well. And we may see in some people a history of psychotic features, or they might be present now, and we always want to assess for that. So the diagnostic criteria for major depressive disorder. So they have anhedonia or a depressed mood or both. They have a depressed mood most of the days, nearly every day a week, as indicated by a subjective report or observations of others. In children, this could be irritable mood. Marked anhedonia in all or almost all activities of daily living. So anhedonia, that is when they don't find joy in it. At least 3 or more significant symptoms present during the same 2-week period that represents a change in previous functioning. Significant unintentional weight loss or gain of more than 5% with an increased appetite, usually a co-occurring craving for specific foods such as carbohydrates or sweets. We might see hypersomnia, so sleeping more than normal, or insomnia nearly every day, psychomotor agitation or retardation, fatigue, loss of energy, self-deprecating comments or thoughts, feelings of worthlessness or excessive or inappropriate guilt nearly every day, decreased concentration and memory, and then thoughts about death. Symptoms often begin within 2 months of a significant loss, such as the death of loved one, and do not persist beyond 2 months, are generally considered bereavement and not major depressive disorder. So if they've lost a loved one and it's been within 2 months of that loss, this would not indicate major depressive disorder. These symptoms, they would indicate bereavement disorder. So mental status findings, the things that we may see in people with major depressive disorder, their appearance, they might look tired and unkempt. Clothing show little attention or care about how they look. Sometimes they'll wear dark clothes or loose-fitting clothes. and a significant weight change, their mood will be sad, depressed, anxious, irritable. So mood is what they say they feel. Affect is what you see. So they might appear to be constricted or blunted. So that means, blunted is the tone of their voice is like very monotone. There's not a lot of facial expression. They're just kind of like blah. Sad, tearful, anxious, irritable. Their speech might be slowed. Again, that monotone speech. The thought process might be disorganized. We might see that pseudo dementia. We might see slowing, distractibility. They might be ruminating about the same thing over and over again. What they might be thinking about is kind of pre-morbid preoccupations. They might have those thoughts of self-harm. They're usually oriented to person, place, and time unless psychosis is present. Usually impaired recent and short-term memory, concentration, usually significantly impaired. Abstract ability on proverb testing, usually intact if concrete, assessed for other psychotic findings. Insight may be intact or impaired, and judgment may be impaired due to them having, thoughts about harming themselves or not taking care of themselves. And then when we look at, thoughts of death and idolizing it, right? It can happen on a spectrum. So it can be guilt for not being able to overcome their depression or for what they are putting their loved ones through. There might be thoughts that others would be better off without them if they were gone, transient thoughts about harming themselves, nonspecific thoughts of active action to commit this harm to themselves. I don't think I'm supposed to say this word, so that's why I'm kind of going around it. At least on YouTube, I'm not sure. Specific plans with a timeline to complete this act, specific plans with acquisition of the means to carry out the plan, desire to give up their struggle, attempt to end significant emotional pain, lack of visible options for dealing with stressors, they're hopeless and helpless, and then anger and frustration with poor impulse control. So when we're doing an assessment of people who want to harm themselves and ultimately cause death to themselves, it's usually high for people with certain symptoms or history. So if they have a history of psychotic symptoms, if they have a history of past attempts, if they have a history of a first-degree relative who committed the same act, if they have concurrent substance use or dependency, and if they have a serious health problem. And when we're assessing, we want to look at the history for both themselves and their family. We want to look at how they view the world. Do they have a lot of negative views of the world? Do they currently idolize the thoughts of harming themselves? Do they have a plan and intent to conduct this action? Do they have means to conduct this action? Do they have social supports? And then we want to look at, if they say to us, oh, I have a plan or a way they're thinking about doing it, we want to look at the lethality of it. So for example, jumping from something, a gun or hanging, those are all high lethality, where moderate lethality is going to be like overdosing, and then low lethality is going to be superficial risk cutting or breath holding. Like I'm going to hold my breath until I harm myself, right? That's going to be more of like a low lethality. We want to look at impulsivity, substance use or dependency, and then a history of psychiatric disorders. Diagnostic and laboratory findings. So there's no laboratory findings for major depressive disorder. We do want to look at things like a CBC, a chemistry panel, thyroid functions, B12, and folate to rule out other metabolic causes and unidentified conditions. We want to consider referrals for sleep studies if they have snoring, apnea, or sleep disorder. We want to look at a tox screen, and we want to look at endocrine disorders. For example, hypothyroidism can present looking like depression. We also want to look at diabetes, hyperaldosteronism, Cushing's, and Addison's disease. So other things we want to look at, neurological disorders, lots of examples of those, cardiac disorders, infectious and inflammatory states, psychiatric disorders, nutritional disorders, and other disorders. So I'm not going to read them all, but they are there. You can pause it if you'd like to read. Medications that can cause altered mood states. So these are important to know for the exam, especially steroids. Steroids can cause mood changes in people. It can cause both depression or mania. Also, antihypertensive drugs, anti-Parkinson agents, anti-neoplastic agents, antibacterial, antifungals, analgesics, benzodiazepines, all of these things can cause altered mood states as a side effect. So our clinical management, so the top goal is always client safety. So if you have a question on the exam that's like, what is your priority for this patient with some type of depressive disorder, right? And it could be something else, could be another disorder, but safety is always going to come first. So you need to do what is going to make that patient safe in the moment. That's step one. If it's saying priority, because it wants to know what's like the first thing you're going to do. Reasons for brief hospitalization during acute episodes of major depressive disorder. So we may have to keep them safe. We might have to make medication changes that can't be done on an outpatient basis. They might need restabilization. We might need to monitor their self-harm. And we might have to ensure compliance with treatment. Clinical management during non-acute episodes occurs most often in the community, and we'll have both pharmacological and non-pharmacological management. When we talk about pharmacological management, so one thing is most of these medications are going to take 4 to 6 weeks to start having the person feel relief of their symptoms. So patients should know that you can't just take one dose of an SSRI and you're going to feel better. Even a week after starting an SSRI, you're probably not going to feel better. It is going to take a full 4 to 6 weeks. And once started, they're going to want to continue that antidepressant for a minimum of 6 to 12 months. And if they've had 2 prior episodes of major depressive disorder, they may need them forever. Not all symptoms of major depressive disorder will respond to pharmacological treatment. Research has found the most effective intervention is a combination of medication and therapy. An antidepressant rebound or withdrawal is common when people stop antidepressants abruptly. So we don't want to do that. The worst is going to be seen in those antidepressants with a short half-life. So first line is always going to be usually, I shouldn't say always, first line is typically, that's a better word, selective serotonin reuptake inhibitors, so those SSRIs. That's because serious side effects are very rare, and they are much safer in an overdose than other antidepressants such as tricyclics or MAOIs. After the SSRI, second line is, I wouldn't even say this is second line. This was in one of the notes as second line, so I wouldn't say it's second line though, because you could use ECT first. You could augment the SSRI with a second generation antipsychotic. You could switch from an SSRI to an SNRI. You could switch to buprenorphine. So it's like, but if like all those things don't work, then, might go to a TCA. And the thing is, TCAs work well, but they have a lot of side effects. So they're not always used first line. And one of their side effects, they can have electrocardiogram changes and cardiac dysrhythmias. They're also toxic in an overdose. If people stop, they're going to get discontinuation symptoms. And again, because they're toxic in an overdose, we want to be careful not to give them to people with past, or thoughts of self-harm that they have. And all antidepressants have a black box warning that they can increase thoughts of harm against oneself in children and adolescents. So we have a whole discussion on psychopharmacology. So in that one, we're going to go each of the medications, but I have some of them listed here. So we'll go through, but we're going to go through quickly. So antidepressants. So one thing to know about antidepressants, if people with bipolar disorder take an antidepressant, they're at risk of going into a mania. So that is important to note. Typically, this is how people find out that they have bipolar disorder, is because typically bipolar disorder starts in a depressive episode. So people will have a depressive episode, start an SSRI, and then they'll go into a mania. And then we know that it's bipolar disorder, typically. So commonly used antidepressants, we have our selective serotonin reuptake inhibitors, those SSRIs, and examples, citalopram, fluoxetine, paroxetine. And adverse effects are usually GI symptoms, drowsiness, nervousness, insomnia, and sexual dysfunction. Sexual dysfunction is probably one of the main reasons that people get switched off of these, unless they don't work, and then they'll get switched to something else. Then we have tricyclic antidepressants. This is like amitriptyline, doxepine, desipramine. They're similar to SSRIs, however, they have significantly more side effects. They're anticholinergic, they have drowsiness, weight gain, orthostatic hypotension. We have MAOIs, which work for depression. However, we don't use them often just because you get a hypertensive crisis when you eat certain foods, which are like really yummy foods like wines, cheeses, meats, beer, anything that's kind of like fermented in a way, you can't have, and because you'll have this hypertensive crisis. And then SNRIs, venlafaxine, duloxetine, these increase norepinephrine and serotonin, but they do have side effects. They pretty much have all the same side effects of SSRIs, but then they also have the side effects of increased norepinephrine. So they're going to have that like tachycardia, sweatingness, increased blood pressure. And then we also have medications like bupropion, which inhibits norepinephrine and dopamine, but can have some side effects like anxiety, insomnia, and tremors. Vilazodone is a serotonin partial agonist. So it increases serotonin, but only to a certain point, not as much as kind of the other ones, but can have some, and a serotonin reuptake inhibitor. So it has some adverse effects like nausea, diarrhea, headache, and weight gain. And vortioxetine is a multiple serotonin modulator and uptake inhibitor, but again, similar side effects to SSRI. Okay, so this slide is a repeat slide of what you're going to see in the psychopharmacology lecture. Just to quickly refresh, we remember serotonin-specific reuptake inhibitors. These work by the little serotonin elongated yellowy golds. Things come in and they block the serotonin reuptake channel, which what that is doing is it's pulling these bright yellow dots, which are serotonin, back up into the presynaptic cell to be looped back around. But we don't want that. We want to increase serotonin in the synapse, the space between the presynaptic cell and the postsynaptic cell, so that the postsynaptic cell can get triggered more by the serotonin because there's more there. And that's how we increase serotonin. So what you're going to see, these are again the same slides from the psychopharm lecture. There's a few extra points here that aren't in the psychopharm lecture. So we'll go through some of it. So Prozac, important to note, this has the longest half-life. Therefore, it has to be, if you're going to switch it to another SSRI, it has to be switched the most carefully because it will stay in the system longest. This medication is good for people who are not good at taking their medications because, again, it is going to stay in the system the longest. So if they miss a dose, they're not going to feel those withdrawal symptoms. There actually is a type of Prozac that only has to be taken once a week, which is pretty cool and really good for people. This is a pregnancy category C and a lactation category L. And this one is going to require 6 to 8 weeks to start to feel that full therapy or have the full therapeutic trial. So if people take it for 4 weeks and it's not working, we don't want to say this doesn't work. We want to give it a full 8 weeks. In some people, it can cause activation because it mildly blocks the reuptake of norepinephrine. So it mildly increases norepinephrine. So some people can get what's called an activation. This is like nervousness or insomnia. In kids, they might have violent kind of outbursts. And then we know this probably isn't the best medication for them, and we can switch it to something else. And it has been used a long time, and it's used for many other things like bulimia, anorexia, PTSD, personality disorders, OCD, panic disorders, and premenstrual symptoms. All right. And then we have Zoloft. So Zoloft, and you can kind of see on the side. So you see how it has the serotonin with the little plus. So that's because Prozac is increasing serotonin and mildly increasing norepinephrine. So it's like, how do these medications, although they're all SSRIs, how do they work different? And they do subtly work different. And we're going to see that on some of these slides. So for example, now we have Zoloft. So we can see that Zoloft increases serotonin, but also slightly increases dopamine. It's indicated for PTSD and useful for premenstrual symptoms. In premenstrual symptoms, it can be used 5 days before and 5 days after menstruation. Side effects are that it has harsher GI side effects than other SSRIs, sexual dysfunction, somnolence, and headaches. If we tell people to take it with food, that can help with some of the GI upset. It is also a pregnancy category C and a lactation category L2. It moderately blocks dopamine reuptake, rare, but it can cause psychosis in genetically susceptible individuals. Side effects are nausea, insomnia, somnolence, headache, dry mouth, and sexual dysfunction. Half-life is 1 day, so it can be useful to use for a weekend drug holiday. So some people might not want to take it on the weekends. That'll be okay. And this can help to improve sexual side effects, but the half-life is long enough that they won't feel the serotonin withdrawal. Then we have Paxil, or paroxetine. So this is a more potent serotonin reuptake blockade than other SSRIs. It is rapidly absorbed, so it does have worse side effects when it's first started. It has a high level in the bloodstream for faster, so it does have that discontinuation syndrome. Side effects are headaches, GI disturbance, somnolence, sexual dysfunction, and some weight gain. It's a pregnancy category 2, a lactation category L2. It has the most anxiolytic effect. It's FDA approved for general anxiety disorder, panic disorder, and social phobia. It has moderate anticholinergic effects. So in a susceptible person, it can lead to dry mouth, sedation, constipation, and cognitive side effects. And it has a high risk for sexual dysfunction, weight gain, and discontinuation syndrome due to its short half-life. Then we have Celexa, or citalopram. This is the most potent serotonin reuptake inhibition. It is the most purely serotonergic agent in the SSRI class. Very similar side effects, right? Sedation, sexual dysfunction. Some people can have agitation, yawning, GI disturbances, weight gain. It minimally affects hepatic enzymes and has minimal drug interactions, has a high tolerability and works for many people. However, it can elongate the QTC interval, and we talk about that at another time. At higher doses, if it's over 40 in adults or 20 in the elderly, it can cause cardiac arrhythmias. It's not effective for bipolar depression, and it is a category C and lactation L2. Lexapro. This is citalopram. So side effects are somnolence, headache, sexual dysfunction, and GI dysfunction. It's a pregnancy category C, a lactation category L2. Luvox, or fluoxamine. This is an old SSRI that is actually FDA approved for OCD rather than major depressive disorder. You're going to, again, have very similar side effects because we are modulating serotonin in a pregnancy category C and lactation category L2. So vilazodone, this is also called Vibrid. This is a serotonin partial agonist reuptake inhibitor. It's a derivative of trazodone, but less sedating. It has less sexual dysfunction than other SSRIs. Side effects include diarrhea, nausea, dry mouth, and it is a pregnancy category C, and the lactation category is unknown. Vortioxetine, or Brintellix, this is similar to trazodone and vilazodone, but with a higher serotonergic potency. It has a long half-life of 66 hours, so very minimal withdrawal symptoms. Nausea, dizziness, and diarrhea are the side effects, and it is a pregnancy category C and a lactation category L3. So we can see for most of these medications, they are pretty much the same, pregnancy category and lactation category. So this is just overview of individual serotonin reuptake inhibitors that we just talked about and some of the information over on the side. Just a nice summary. And general tips for SR. So most Mostly all of them will be taken in the morning, with the exception of Paxil, which can be sedating, and fluoxetine, where some people do experience sedation. If that is the case, it is okay for them to take it at night. Fluoxetine requires a longer therapeutic trial, but has less serotonin withdrawal. Sertraline works well for those weekend holidays. Citalopram is the most selective for serotonin reuptake. Sertraline and citalopram have the fewest drug interactions. Paroxetine may have the most anxiolytic effect. And observe carefully for what's called a mixed state. So a mixed state is like, you might have like depressive symptoms with like racing thoughts. So it's kind of like a mixed state. They're not in like a full depression. There's like those mixed kind of manic-y, depression-y kind of things going on. Diagnosed bipolar disorder, as well as akathisia, as possible risk factors for harming oneself. All right, so again, we're going to go over all of this in the psychopharm lecture, but here are all the SSRI side effects highlighted in red. All of the SSRIs are going to have these as side effects. Some people may have vivid dreams and have mid-cycle awakening from them. So then we have serotonin norepinephrine reuptake inhibitors, or SNRIs. The first one is Effexor. So again, we're going to go over this in psychopharm lecture. So a lot of these SNRIs are going to have hypertension. Effexor is the one that is most commonly associated with discontinuation syndrome. So we want to taper it. It's discouraged to use this in patients with alcoholism or liver disease, as it can cause rare liver toxicity. It can cause cardiovascular. It holds a cardiovascular risk of sudden death. We want to be careful. Really probably don't want to use this medication in people who have cardiac kind of conditions. Has double the risk of causing mania in those with bipolar depression compared to other SNRIs or SSRIs, and bupropion, more effective than other SNRIs in refractory clinical depression, and it's a category C for pregnancy and a category L3 for lactation. Pristiq is usually given once at night, and it's very similar to venlafaxine, as it's called desvenlafaxine, right? Very similar. Cymbalta or duloxetine is more potent in its norepinephrine reuptake blockade. It's given once at night. It can also be used in patients with fibromyalgia, diabetic neuropathy, and premenstrual symptoms. It's been shown to help physical pain symptoms in depression. Side effects are dizziness, headache, GI disturbances. It can elevate blood pressure and liver function tests, and it does cause discontinuation syndrome. And again, pregnancy category C and lactation category L3. Levomilinacipram, not sure how to say this. Honestly, don't see this often, but given once at night, similar to venlafaxine, may help depression related to chronic pain. Side effects: nausea, vomiting, constipation, sweats, palpitations, urinary hesitancy, hypertension, hypotension, or decreased appetite. And again, pregnancy category C. And here are all those SNRI side effects. You're going to have both the side effects of serotonin and norepinephrine, and these are contraindicated within 14 days of having taken an MAOI. And then we have noradrenergic and specific serotonergic antidepressants. That's a mouthful. So one of them is called Remeron, and Remeron, it's different than other medication. So it inhibits the inhibitory input to the sympathetic nervous system and enhances sympathetic output, which means that it counteracts some of the symptoms of depression. For this, it helps to decrease nausea and increase appetite. So it's really good to use in people with cancer or in nursing homes. However, it can be sedating about half the time. So we want to give it before bed, and it has lower frequency of side effects that are seen with other antidepressants. And it has an inverse relationship between sedation and dosing. So lower doses sedate more than higher doses. It's a pregnancy category C and a lactation category L3. Then we have norepinephrine and dopamine reuptake inhibitors. This is bupropion. I always think that is very interesting if we look at the structure of Wellbutrin and the structure of dextroamphetamine. It's kind of similar, which is interesting, right? So it's Wellbutrin, it's going to give people more energy. It's actually mildly stimulating. It is not sedating at all. It increases dopamine and norepinephrine, and it doesn't really affect serotonin. So this works well for people who don't want those sexual side effects. It's also used to treat ADHD. Some of the side effects include headache, insomnia, dry mouth, tremors, nausea, agitation, irritability, but it does lower the seizure threshold. We don't want to use it in people who have seizures or people in active eating disorders with electrolyte imbalances. Usually these side effects will improve after a week or two. Wellbutrin SR is the slow release version and reduces the seizure risk from 0.4 to 0.1. It really has a low or no risk of causing mania. It's ineffective for bipolar depression, and we want to caution people with drinking caffeine and those with panic disorders from taking this. We want to just let them know it could make that worse. Then we have serotonin antagonist and reuptake inhibitors. So the first one is nifazodone. Side effects include headache, drowsiness, GI disturbance. It's a pregnancy category C, lactation category L4, so it should be avoided. It's safer in an overdose than other TCAs, but we must monitor LFTs and can cause liver failure. Distrel or trazodone, this is less likely than some other antidepressants to cause insomnia, sexual side effects, and anxiety. It's not a well-tolerated antidepressant due to its sedation. We typically use it for sleep. Side effects are drowsiness, nausea, dry mouth, and priapism, which will require urgent urology intervention. It's a pregnancy category C, category B. It's the only one so far that hasn't been a C. In lactation category L2. Then we have our tricyclic antidepressants. So it's going to have a lot of side effects. You're going to get the anticholinergic side effects. You're going to get EKG changes. They are unsafe in co-occurring disorders like cardiac disease. They can induce hypomania in people, toxic in an overdose, causes discontinuation syndrome. Adhere to a 2-week washout period, 5 weeks for fluoxetine before switching between an SNRI and a tricyclic. So again, here are all those side effects. This is used typically for treatment-resistant depression that has failed multiple other alternatives. So one of them is trophanil. Sometimes this is used for nocturnal enuresis in kids due to the anticholinergic effect or separation anxiety. It was the first antidepressant ever developed, but it's not used as first line. Norepinephrine, also used in ADHD, same category C and category L2. Anifranil is only FDA approved for OCD, a more effective option for OCD than other treatments, but not used first line because of all the side effects. Elavil is used for chronic pain, depression, diabetic neuropathy, and can also be used for insomnia. Pamelor is used for enuresis in ADHD and is a pregnant category D. Sinequan or doxepin is used for insomnia, category C, category L. Vivastil, pregnancy category C, no lactation category data. Sermontil, category C, and no lactation category data. These are just ones you may see. These are the rarer ones, so I'm not going into super detail. You're not going to see these on the test. Then we have MAOIs. So these can be fatal in an overdose. They cause a hypertensive crisis when they're taken in conjunction with certain foods, but also certain medications. So decongestants, TCAs, antipsychotics, St. John's wort, L-tryptophan, asthma medications, symptoms of a hypertensive crisis. So they're going to have an explosive headache, typically in the region around their eyes, sudden elevated blood pressure, facial flushing, palpitations, pupil dilation, diaphoresis, and fever. The treatment for this is to discontinue the medication, give phentolamine, which binds to the norepinephrine receptor sites, and stabilize their fever. All right. And so these are all like the foods you can't eat. Again, things that are good: pickles, soy sauce, meats, beers, wines, and cheeses. Pretty much it causes the tyramine to build up on the vessels. It causes the vessels to constrict. And these are 3 MAOIs that you may see. MAOIs can sometimes also be used for panic disorder, phobia disorders, and selective mutism. It's a category C for pregnancy and has a lot of side effects. Here's another MAOI. All right. So here is just a nice summary of all the things we just talked about. The FDA approved medications to treat major depressive disorder. So we can see, we talked about the antidepressants. There's also second generation antipsychotics. And then we see the antidepressants we talked about on there as well, and the typical dosing range. So when we talk about one of the side effects we have to watch for with medications that augment serotonin, so those SNRIs, SSRIs, we're looking for serotonin syndrome. The thing is, with all of these kind of major red flag side effects that we look for, they all look the same. We're going to go over this more in the psychopharm lecture, but for serotonin syndrome, agitation, confusion, headache, they're going to be hot, they're going to be sweating, tachycardic, dilated pupils, agitation. And if this goes untreated, the mortality rate is 2 to 12%. So we want to be able to identify and properly treat. So non-pharmacological management for depression. So there can be ECT. There's also something called TMS, which is like a magnetic stimulation through the scalp. There's VNS, which is a surgical implanted electrode around the vagus nerve. There are psychotherapies like CBT, and then also exercise can actually help with depression as well. So when we talk about ECT, this is when we induce a grand mal seizure on a person who is under anesthesia. It's usually 6 to 12 treatments. The way it works, so there's a couple theories. One is the neurotransmitter theory, which states that it increases dopamine, serotonin, norepinephrine. One is the neuroendocrine theory, where the release of hormones such as prolactin, TSH, pituitary hormones, endorphins, and adrenocorticotropin hormones. Then there's the anticonvulsant theory, which exerts an anticonvulsant effect, which then produces an antidepressant effect. ECT is used, it can be client's preference, it can be the need for a rapid response. Say people aren't eating or drinking and they're not responding, right? That would be a good time to maybe do something like this, right? Because if they don't eat or drink, they could harm themselves. If there's major depressive disorder with psychotic features where the risk of other treatment outweighs the risk of ECT, and those that are treatment resistant, we don't want to use this treatment in people with cardiac disease, compromised pulmonary status, a history of brain injury or tumor, anesthetic medical complications, possible cardiovascular effects, and systemic. So adverse effects we can see are possible cardiovascular effects, systemic effects, and also cognitive effects. TMS, so this works for people who haven't had a response to medication or psychotherapy. They place a small wire coil on the scalp and conduct electrical currents, creating a magnetic field through the tissue of the head. It's performed in an office setting without anesthesia. It's typically about 40 minutes, and you need about 5 sessions per week for 6 weeks. Side effects are minimal, but can include headache, scalp discomfort, tingling, twitching of the muscles, lightheadedness, and seizures, although they are rare, have been reported. Vagus nerve stimulation. So again, people who don't respond to medications or psychotherapy, a pacemaker-like device is placed on the left side of the chest to stimulate the left branch of the nerve. Generally done on an outpatient procedure, but anesthesia is required. Side effects occur as the pulse generator stimulates the vagal nerve and includes voice changes, hoarseness, cough, throat or neck pain, chest spasms, dyspnea on exertion, tingling of the skin, and dysphagia, intended for use along with traditional treatments. So phototherapy, this is like using a bright light for 30 minutes, up to 2 hours and 1 to 2 times a day. This is also great for people who have seasonal affective disorder, having that bright light. Sometimes, you can have people put it at their desk as they're doing work, or people, if they're doing like their makeup in the morning, you can put it there. So it's like a few minutes of kind of like getting that light, 30 minutes to 2 hours, 1 to 2 times a day. So non-pharmacological treatments, so individual therapy, such as psychodynamic therapy or cognitive behavioral therapy, brief therapy, group therapy, family therapy, and there's just some examples there of the different things that can be included in each type of therapy to target the major depressive disorder symptoms. Clinical management of wanting to cause death to oneself. We want to pay attention to positive assessments for them wanting to cause harm to themselves. Assume that the client is serious when they make these statements. Identify current stressors that are contributing. Generally, you do not manage in the community setting during acute episodes unless the client is able to make a no harm agreement. So again, this is like stuff that I got out of, books that I was reading and studying for this and things, but you want to be careful with no harm agreements. The more recent research is saying that like a contract for safety actually is like not good, because it doesn't hold any weight when the research actually looked at it. I don't want to get too off topic on this, but I just think, just as a side note, in your practice, a contract for safety, the research is showing that it doesn't really work. Consider hospitalization, consider mobilizing available social resources. So risk factors for harming oneself and causing death: age 45 or older in male, 55 or older in women, divorced, single, or separated, white ethnicity, living alone, a psychiatric disorder, psychiatric illness, substance use, previous attempt, a family history of attempt, or actually completing, recent loss, and male gender. Lifespan considerations. So for children, the core symptoms of major depressive disorder are really the same, but they might have more somatic complaints. So headaches, stomach aches, irritability, social withdrawal. Core symptoms are less common in children before puberty, so you might not see like psychosis, motor retardation, hypersomnia, increased appetite. Children usually do not respond well to tricyclics. They do respond well to SSRIs. Major depressive disorder often has a strong separation anxiety component in children. In older adults, persons with major depressive disorder admitted to a long-term care facility have a significant shorter lifespan than most people. 65% are more likely to die within the first year of a long-term care facility. Cognition and memory symptoms of major depressive disorder in older adults often are confused with dementia. Clients with dementia usually have a premorbid history and a slow decline. And in major depressive disorder, the symptoms are usually faster. We talked about this earlier. It's important to complete a functional assessment in older adults to see what their ability and their performances are and how it compares to the demands of their life and the impact the illness is having on them, and identify any skill deficits or performance deficits. Reasons to perform these functional assessments is to correctly diagnose, to track their improvement or decompensation, to help families realize expectations, to understand their activities of daily living and if they're able to conduct them, and their executive functioning. You can monitor this like every 6 months. All right, so that was major depressive disorder. Now let's move on to another depressive disorder. Now, all of these are not going to be as long as that one. That was kind of like setting the stage for us. Persistent depressive disorder. So this is also called dysthymia, and it affects 5.4% of the US population ages 18 or older. They're more likely to get major depressive disorder, similar to major depressive disorder, but less acute symptoms. It does have a chronic disease course, no psychotic symptoms. Symptoms of this can go undetected and therefore untreated for years, and vegetative symptoms are much less common. Risk factors are genetic predisposition, a first-degree relative with major depressive disorder or with dysthymic disorder, and female gender. Symptoms include chronically depressed mood that occurs most of the day, more days than not, for at least 2 years or 1 year in kids, a presence of low self-esteem, self-criticism, and a perception of general incompetence compared to others, low energy, fatigue, poor concentration, difficulty decision-making, feelings of inadequacy, hopeless, mild anhedonia, social withdrawal, brooding about past issues, subjective irritability or anger, decreased productivity and activity. Less common symptoms include changes in appetite or sleep patterns, and they may describe themselves as my mood has been down all my life. Management, similar to major depressive disorder, and because of the increased risk for developing major depressive disorder, dysthymia is often treated with antidepressants, similar to major depressive disorder. So common comorbidities. So again, thinking of major depressive disorder, the subjective worsening of symptoms or the onset of new symptoms often brings the person into treatment, associated with several childhood disorders such as ADHD, conduct disorder, anxiety, and learning disorders. And dysthymic disorder is associated with personality disorders such as borderline, histrionic, narcissistic, avoidant, and dependent. So then there's grief and bereavement disorder. So it's a normal response that becomes an abnormal and excessive. It involves normative, emotional, cognitive, and behavioral reactions to death or loss of a significant person or object. Unlike in major depressive, self-esteem is usually preserved in the grieving person. It involves non-normative psychological responses to an identifiable stressor that can result in the development of a clinically significant emotional or behavioral symptom. Stressors encompass elements of perceived loss, and it develops within 3 months of a stressor. A single event can be the end of a relationship or the death of a relative or partner. It can be a recurring event or a developing event like leaving a home to go away to school, getting married, becoming a parent, or retiring from work. Adjustment disorder, this is another disorder, is the absence of other significant clinical symptoms. Grief usually is classified as adjustment disorder. So it can be adjustment disorder with depressed mood, with anxiety, with mixed anxiety and depression, or with disturbed. Things that we'll see in our assessment is the client will not disclose grieving or bereavement issues unless directly asked. We want to assess for the following: a recent loss, anniversary date of a past loss, reaction to a loss, functional impairment, social and family support systems, insomnia, anorexia, denial, dysfunctional coping, thoughts of harming themselves, or substance use. Mental status exam will see depressed mood, anxious affect, or crying uncontrollably. We want to do all of these labs to rule out metabolic causes, just like we did with major depressive disorder, and then also a tox screen if indicated by the history. So in managing this, we can use things like benzodiazepines or non-benzodiazepine hypnotics such as zolpidem, tricyclics, or other sedating antidepressants or antihistamines. Non-pharmacological, we can use support groups, help them to express grief and loss, offer community resources, offer psychoeducation on grief, and with significant functional impairments, we can consider psychotherapy. We want to follow up weekly if it's an acute episode, monitor for the development of major depressive disorder, monitor the impact on their general health, support them over time, be sensitive to non-traditional losses that may be significant to the person, such as loss of a pet. I would argue that that is significant, or loss of status at work or a school setting. Then we have premenstrual dysphoric disorder. So dysphoric symptoms that occur in response to changing sex steroids, hormones which occur during the ovulating menstrual cycle. Symptoms generally begin during the luteal phase about 1 week before menses and generally lift within a day or two once menses have begun. They'll have feelings of marked lability, irritability, depressed mood, anxiety, low energy, and sleep disturbances. And symptoms typically occur every month, and there must be a symptom-free period in the follicular phase after menses has occurred. Symptoms may worsen as the woman becomes perimenopausal. Symptoms cause marked impairment in functioning and sense of well-being. A careful evaluation must be completed to rule out another mood disorder, and treatment may consist of hormonal contraceptives, SSRIs, antidepressants, or both. All right. So now we've talked about all of the different depressive disorders. Now we're going to talk about the bipolar disorder. So with bipolar, our mood changes between those periods of depression, but also moves to these periods of either mania or hypomania, these kind of highs. So that's the highs and lows. It's important to identify that with bipolar disorder, it is not a high and low during the day. It is not an emotional lability during the day. Like a person that 1 minute is like happy and next thing you know, they turn around and now they're screaming at you. That's more probably a personality disorder, not a bipolar disorder. Bipolar is going to last, those mood states are going to last from like usually weeks to months, that they are kind of in this like high or they're in this low. All right. So With bipolar disorder, it is a complex brain-based illness with a primary characteristic of a disturbance in mood. It goes between two poles of depressive or expansive or manic. It has several patterns. So there's single polarity. There are distinct symptom patterns of alternating polarity. So manic symptoms alternating with depressive symptoms, and then a mixed co-occurring symptom. So that is kind of that mixed state we talked about earlier. It presents with excessive or distorted degree of sadness or elation or both. It manifests with behavioral, affective, cognitive, and somatic symptoms, and has complex genetic, biochemical, and environmental etiological factors. So 2.1% of the population has bipolar. It's similar for men and women. 10 to 20% die by self-inflicting something to themselves, causing death, which is very high if you ask me. It's usually an episodic course, gradual changes in mood. So again, days to weeks, it's not changing throughout the day. Usually hurting themselves or thoughts to hurt themselves are in the context of mood symptoms. So non-serious self-injury is less common. So things like cutting to cope or burning to cope, it's less common. Psychotic symptoms only in the presence of mood symptoms. Family history of mood disorder, interpersonal relationships are usually preserved. So these, with bipolar disorder, these aren't people that have difficulties with relationships, right? So that's going to be the personality disorder. So like we talked about the mood changes during the day, up and down, that's more personality disorder. Bipolar is going to be the mood changes over several days, and they usually do have good relationships with people. Highly comorbid with anxiety, ADHD, and substance use. First line treatments are going to be mood stabilizers, second generation antipsychotics. Those typically are the first line. And then adjunctive, we can do psychosocial or behavioral interventions. So what causes it? It's probably multifactorial. There's thoughts that it could be GABA dysregulation, increased noradrenergic activity, voltage-gated ion channel abnormalities that lead to abnormal balances of intracellular and extracellular levels of neurotransmitters, which then cause subsequent disruptions of electric signal transmissions in the brain. Something called kindling. This is the tendency of some regions of the brain to react to repeated low-level bioelectrical stimulation by progressively boosting synaptic discharges, thereby lowering the seizure threshold. So long-lasting epileptogogic changes induced by daily subthreshold brain stimulation, the brain becomes overly sensitive to electrical stimuli, neuronal misfiring occurs, and the process becomes automatic and neuronal firing occurs even without a stimuli. And the age of onset is usually in the 20s. Risk factors, so genes, a relative that has major depressive disorder or bipolar disorder, 24% increased risk if a relative has bipolar disorder type 1, 5% if it's a bipolar disorder type 2, and 25% increased risk if the relative has major depressive disorder. So prevention and screening, we want to do at-risk family education, community education, early recognition, intervention, and initiation of treatment. Very similar to major depressive disorder. So history, again, very similar to what we talked about with major depressive disorder. We're doing a full history. We're doing a full history for really any of these psychiatric illnesses because we need to paint a full picture. All right, so laboratory tests that may suggest alternative diagnoses to a bipolar disorder. So we want to look for if they're saying that they feel fatigued, we can do a CBC, they might have anemia. If they're feeling fatigue and confusion, we can do a metabolic or chemistry panel. They may have abnormal sodium levels. If they are having any indicated mood symptoms, let's look at a TSH to see maybe it's hyperthyroid or hypothyroid. Mood changes or psychosis in women, they might be pregnant. If they have confusion, they might have a UTI. Let's get a urinalysis. Confusion or delirium, we want to look at acute mood changes. We can do a drug screen. Agitation or confusion, we can do ECT. Maybe they have prolonged electrocardiogram, maybe they have a prolonged QTC, which all of these things can suggest a cardiac event. And mood changes, personality changes, we can do a brain CAT scan or MRI. They might have a stroke, tumor, multiple sclerosis, or intracranial hemorrhage. So it's not always bipolar, right? There's other things we can kind of look for. So diagnostic criteria. So a period of abnormal or persistently elevated, expansive, or irritable mood that lasts at least a week. Mood episodes have a rapid development and escalation of symptoms over a few days, often precipitated by a significant environmental stressor. Mood disturbance may result in a brief psychotic symptom. Manic episodes last days to several months. Briefer duration and ending more abruptly than major depressive episodes. In 60% of people, a major depressive episode immediately precedes or follows the manic episode. So when we talk about bipolar disorder, these are the symptoms you're going to see in a depressed episode, and then the symptoms you're going to see in a manic episode. So we just talked about major depressive disorder and what depression looks like, right? Those SIG caps. You're going to see those same things in the depressive episode. With the manic episode, you're going to see elevated or expansive, or in some people, irritable moods. Increased goal-directed activity, high risk-taking behaviors, grandiose or inflated self-esteem, decreased need for sleep, increased energy, distractibility, impulsivity, psychomotor agitation, pressured speech, flight of ideas. They're typically going a mile a minute. That's kind of the best way to think about it, right? They're like very goal-directed, very energized, sometimes irritable, and they don't sleep. So those are like the signs that you're going to see with a manic or hypomanic episode. When we say manic and hypomanic, manic is kind of like the bigger version of hypomanic. So somebody hypomanic might be getting 4 hours of sleep every night. They might decide one day they're going to start this business and this thing that they've never done before. They might spend like $10,000 doing it, but they're still sleeping. You know, that might be a hypomanic episode, where a full manic episode might be they haven't slept in 2 weeks. They spent all of their life savings on buying $500 dolls. Like, I'm not even kidding. You know, just like very not able to function in society. Like a manic episode, you can't function in society. A hypomanic episode, you can function in society. I guess that's kind of a way to think about it. So mania, a decreased need for sleep, feels rested after a few hours. Usually a marked difference in normal from baseline patterns, inflated self-esteem, grandiose, goal-directed activities, unrestrained buying sprees, sexual indiscretions, unsound business ventures, excessive substance use. So hypomanic, similar to mania, but briefer in duration, not as severe, does not require hospitalization, and does not cause significant functional impact. So you can still function in life in a hypomanic episode. Okay, so mental status exam, what we're going to see with these people, you know, restlessness, agitation, a frequent changing of clothes. They might be wearing bright colored clothes or not much clothes, dramatic or like flamboyant in the way that they're dressing. That doesn't always indicate bipolar, but just to know what you may see. Rapid, loud, pressured speech, difficult to interrupt, joking, irrelevant, or amusing. Word clanging, so making words rhyme as they talk. Their affect may be labile or irritable. It could be very bright and like excited. So that overly theatrical or dramatic. Mood can be euphoric, cheerful, high, expansive, or irritable. They're going to have racing thoughts, flight of ideas, disorganized thought content, so inflated self-esteem, enthusiasm, increased sense of ability, almost bordering delusion, increased sexual content. They're usually fully oriented unless they're psychotic. Memory, usually impaired short-term and impaired recall. Concentration, they're highly distractible. They're generally abstract in their thinking. They can be concrete, especially if they're psychotic. Usually poor judgment. Sometimes they don't recognize that they're ill, so they're resistant to treatment options. Bipolar 2 is characterized by at least one hypomanic episode, and hypomanic criteria is a distinct period of elevated mood or irritability lasting 4 days, and 3 dig fast symptoms. So dig fast is the symptoms of bipolar disorder, which includes distractibility, impulsive, grandiose flight of ideas, agitated sleep, and talkativeness. Differential diagnoses. So if first onset of manic symptoms occurs over 40, we want to look at other medical conditions, which can include endocrine disorders, hyperthyroidism. So hyperthyroid can make people appear manic. Keep that you need to know for the exam. Hypomania can mimic depression, and hyperthyroid can mimic mania. Also, amphetamine use, cocaine use, hallucinogenics, those can all cause kind of a mania thing. If people are withdrawing from opioids, they may appear kind of manic-y. And then all of these medications can make people appear manic. So again, the steroids are on there, cyclosporins. These you want to know. You want to know the medications that can make you manic and the medications that can make you depressed. Okay, so differential psychiatric diagnoses for bipolar disorder. So I think this is just like a nice overview of everything we just talked about on like one slide. So like if you want to go back and study, or you want like a very brief summary, this is kind of the way to see it. So some of them are covered in other lectures like borderline personality disorder, but these are some of the other disorders we can think about when we're diagnosing bipolar disorder. So clinical management, we want to rule out any other conditions that might be contributing to the symptoms. Assess the level of acuity, severity, and duration of illness. Get a history in response to treatment. If it's an acute manic episode or a significant depressive episode, they may require hospitalization for safety, stabilization, and adherence. Monitoring of adherence to medications. So a mood disorder questionnaire. You don't need to remember all of this. It's just so you can see it. There is this questionnaire tool that you can use in your practice to assess for mood disorder symptoms. This is how you rate it. I'm not going to read it all out to you, but this is a tool that you have. You're going to see throughout these lectures different assessment tools. The ones that you really need to know are the ones that are in the Scales and Erickson's lecture, is the name of the lecture. All right. So if a client scores high on the mood disorder questionnaire, these are algorithms for treatment. And I know they're not the best pictures, but just to go through it quick. So just because someone is bipolar doesn't mean that the treatment is going to be the same. The treatment is based on the type of bipolar they're in. So if they're bipolar depression, they'll be treated one way. If they're bipolar in a manic state, they'll be treated a different way. And if they're in a bipolar depression in a mixed state, they'll be treated differently than a bipolar depression in just a depressed state. So that's why these algorithms are nice. So you don't need to memorize the whole thing, but it's just nice to know, right? Somebody has bipolar depression. Is it an urgent need for ECT? Yes or no? Let's say no, because most of the time it's not an urgent need. And then it's to asking you, like, what are their current medications? You know, are they on lithium or olanzapine, no mood stabilizer, anticonvulsants, quetiapine, lurasidone, or carbamazepine? You pick which one they're on, and then it tells you like the next thing to do, et cetera, et cetera. It's nice. Over on the other side, it is asking you, I have to get a little closer. It is asking you, so this is for a bipolar manic state. Is it a mixed state or a regular state? Let's say, no, it's not a mixed state. It's just a regular, they are straight manic. There's no depressive symptoms there whatsoever. It's recommending that you initiate lithium. Now, one thing to note with these algorithms you're going to find online, what one provider does is not necessarily what another provider does. And this isn't the only way to do it. Psychiatry, there is an art to it that is different than other areas of medicine. It is not just like, oh, we test, we swab the infection and we know it's this type of bacteria and we use this antibiotic. It is not like that. There are a few different medications that you could use if somebody was in, a bipolar manic state, not just lithium. Lithium is good, but lithium takes time to work. So we need to assess like the acuity of this person. Would something else have to be on board as well with the lithium? You know, some people might use Depakote. It just depends, right? So this isn't the only way to do it, but this is just one way to do it. And I found algorithms really nice when I was first learning. All right, so pharmacological treatment. So to piggyback off that, if somebody is in an acute mania, somebody who's not in treatment for bipolar disorder, we have to look, is it a severe mania or a mixed episode? Usually these cases, they're hospitalized, and we have to weigh the risks and benefits of treatment. So again, first line, you might use lithium, you might use valproate, you might use carbamazepine, you might use a second generation antipsychotic. You might use a second generation antipsychotic with lithium or Depakote. Second line might be carbamazepine, Haldol, lithium, and Depakote. Third line. So it's just, this is kind of giving you some guidelines, right? Not recommended. So Topamax, Lamictal, Verapamil, those aren't going to work well. Risperdal and carbamazepine, olanzapine and carbamazepine, those aren't recommended for a acute manic episode. And then adjunct therapy, they might need high potency benzodiazepines to target the agitation and aggression or insomnia. And things to remember. So second generation antipsychotics are more rapid onset compared with mood stabilizers. Lithium preferred in patients with the classic euphoric grandiose type of mania. Valproate is preferred with the dysphoric irritable mania or mixed features or comorbid substance use or traumatic brain injuries, or those who have responded poorly to lithium. Now, I will say something to keep in mind with Depakote. I've known providers that will not even give Depakote to a childbearing age woman because it is contraindicated in pregnancy. So you have to think about that too. If you choose to go to Depakote on somebody that could become pregnant, there's a huge risk factor there. So just a note. And then, what are the co-occurring medical issues? Do things happen? If they're on antidepressants, we know antidepressants cause mania, so that's not always the best treatment. Those might need to be tapered off. So these are just some ideas of things you could do. Again, art and science. All right, now if they're in an acute depressive episode, you might want to start lithium or Lamictal. We want to keep in mind that lithium really is the best for thoughts of like self-harm. An antidepressant monotherapy is not recommended because, again, antidepressants can cause people with bipolar disorder to become manic. And we're talking about people with bipolar disorder in a depressive episode. Fluoxetine with olanzapine has been shown to work. It actually has a different name of the medication. I don't remember what it's called off the top of my head. We don't use it often, to be honest. So yes, again, we're in the same thing. These are just some ideas of things that you could do to help people struggling in acute depression that have bipolar disorder. All right, so just some things to think of. So second generation antipsychotics are going to have metabolic indications. They're going to have the weight gain. They're going to increase blood sugars, increase cholesterol. But again, risk benefit analysis, somebody who is super agitated and a danger to themselves and others, like, are you going to sit there and worry about the metabolic side effects? A little bit, but you're also going to take into account that they may hurt themselves or somebody else, and there might need to be some stabilization. So for example, maybe you do a second generation antipsychotic with some lithium with the plan to take away the second generation antipsychotic later down the road. So again, risk benefit analysis. We can continue the second generation antipsychotic if the patient's mania is improved on it. For example, risperidone. There's also some long-acting injectables. If people are on risperidone, they can be given Invega Sustenna. Paliperidone and risperidone are very similar medications, and therefore it's very easy to transition somebody to that long-acting injectable. And again, these are all just ideas of things that you can do for maintenance therapy. So this slide is maintenance therapy. So that's why it's saying caution with second generation antipsychotics. Like, do you want to keep them on long term? You might be able to switch them to something else once they're stabilized. All right. So mood stabilizer dosing strategies and therapeutic serum levels. So for the exam, you will need to know the serum levels of lithium, right? Because lithium has a very narrow therapeutic index, meaning the dose that is beneficial is very close to the dose that is toxic. Typically, lithium starts at 300 twice a day to 300 milligrams 3 times a day, with a usual dose of 900 to 1800 milligrams per day. The serum levels we're looking for depression are 0.4 to 0.8, and for mania, 0.6 to 1. All right. And we want when we get the blood level, it should be 5 days after the dose has started, no sooner, or it will not be accurate. Depakote would typically start 20 to 30 milligrams per kilograms per day, with a maximum dose of 60 milligrams per kilogram per day. So think about that. Milligram per kilogram. That's actually really high when you think of like someone's weight. Serum levels, we're looking for 50 to 125. And the first time we take the blood, the trough is what it's called in this, it should be at least 3 days after dosing initiation or change. And then Lamictal requires a slow dose titration. We start at 25 for weeks 1 and 2, then we go up to 50, 3 and 4, then we go to 100 on week 5, and then 200 week 6. It can go up to a max dose of 400. Therapeutic serum levels we're looking for are 3,000 to 1,400. And the reason we do this slow titration is because we're monitoring for Stevens-Johnson syndrome. People get a rash, and then we need to stop it. So yeah, we talk more about that in the psychopharm. All right, so medications commonly used to treat bipolar depression. So again, we went over all of this. This is like a summary. It is all here. I like charts. This is a chart. It's nice. So I'm going to leave it here. But again, you can see that Stevens-Johnson's side effect is being talked about there under the Lamictal. And again, medications commonly used for bipolar disorder. There are some more with their side effects, etc. And here are some more with their side effects. All right, so we talked about this, the pharmacological treatment. So mood stabilizers. Lithium is the gold standard for bipolar disorder manic symptoms. It also has anti-harm effects. It's neuroprotective, so over time it actually protects the brain of people with bipolar disorder. It has a long history. It's been well established. It has some effectiveness for depressive symptoms. However, it does have side effects, and it has to be monitored carefully because of that narrow therapeutic window. And when we are checking blood work for the level of the lithium, it should be 12 hours post-dose. We also want to look at a thyroid panel, serum creatinine, blood urea nitrogen, pregnancy test, ECG. Rapid cycling doesn't really respond to lithium. So rapid cycling is like they're manic, they're depressed, like very quickly. Not in a day, but very quickly. All right, so this is a nice chart that shows you what the evidence shows as far as what medications treat what component of bipolar disorder. So whether it's type 1 maintenance, type 2 maintenance, acute mania, or acute depression. I like charts. Charts are nice versus me going through and saying which does which. So you can kind of see which medications work for which disorder/symptoms of that disorder. All right. So signs and symptoms of lithium toxicity. So headache, fatigue, nausea, vomiting, diarrhea, polyuria, polydipsia, tremors, arrhythmias. Severe toxicity can have seizures, coma, nystagmus, myoclonic jerks, confusion, disoriented, and cardiac toxicity. Strategies for managing adverse effects of lithium. So it depends which adverse effect, but these are what we can do as management strategies. I don't necessarily think that these are all going to be on the exam. They're just kind of nice to know. And then same with Depakote, some of the adverse effects, and then what we can do to manage them. All right. So anticonvulsants, these are also used to treat bipolar disorder. We want to note that for carbamazepine, there is a black box warning for agranulocytosis and aplastic anemia. For valproate, so Depakote, there's a black box warning as well. Lamotrigine, black box warning for serious rash. Baseline labs for carbamazepine or Depakote, we should get a CBC and liver function tests. Labs drawn 1 week after the start of carbamazepine and Depakote, 12-hour trough serum, CBC, LFTs. Response to treatment with lithium or anticonvulsant is usually 1 to 2 weeks. Olanzapine plus fluoxetine, that's called Symbyax. That was the name I couldn't remember earlier. Latuda is used for bipolar depression. Depakote often manages acute manic and depressive episodes and is useful for the prevention and relapse of both. And carbamazepine can be used to treat manic episodes associated with bipolar. So when we talk about Stevens-Johnson syndrome, which is the side effect most likely to occur with Lamictal that we have to monitor for, they can have facial swelling, tongue swelling. It usually starts as a rash that turns to papules and burning, and their skin starts to slough off their face. It's not good. They'll also get some prodromal symptoms of a headache, malaise, pain on the mucous membranes before the rash occurs. Non-pharmacological treatments that we can use, somatic treatments that we previously discussed in major depressive disorder, therapies that were previously discussed in that major depressive disorder as well. During less acute periods, we can use all different types of therapies. And we always want to be thinking about structuring safety needs, socialization, interpersonal support, discussing symptoms, relapse prevention plans, and overall health promotion. Lifespan considerations. So adolescents, their manic episodes present differently from adults. They have more psychotic features and often are associated with antisocial behaviors or substance use. A prodromal period can occur, which includes things like school truancy and failing grades. And for follow-up, clients should be seen weekly to titrate medications following their serum blood levels. They should be taught the symptoms of mania and depression and the disorder, let them know that it is a chronic illness. Relapse plans should be developed. Client teaching should include the benefits and risk factors of the medications and signs of toxicity. We need to let people know the teratogenic effects of lithium and Depakote. We need to be careful when using these medications with women who are childbearing age and let them know to wear contraceptives, especially because some anticonvulsants, they do reduce how well oral contraceptives work. So there needs to be like a barrier method. We want to do routine labs. We want to assess for self-harm every time we meet with the patients, and use standardized rating scales to monitor the course of treatment. So there is the Young Mania Rating Scale, and we can also use daily mood charts. So here are some mania scales. We went over the mood disorder questionnaire. There's also the Young Mania Rating Scale and the Bipolar Spectrum Disorder Scale. Then there's something called cyclothymic disorder. This is characterized by periods of hypomanic symptoms that do not exceed full criteria and depressive episodes that do not meet the full criteria for major depressive disorder. So we can kind of think of it as like bipolar 1 is like depression here, mania here. Bipolar 2, they have the depression, but they have a hypomania. So it's not as big as the mania, it's a hypomania. And a cyclothymia, they are going to have kind of dysthymic symptoms. They're not like in a full depression, but they're kind of like dysthymic, and then not have manic symptoms. They just have the hypomanic. So it's like a little bit smaller mood spectrum changes. So it's kind of like cyclothymia, bipolar 1, bipolar 2, right? 15 to 50% develop bipolar disorder, usually begins in adolescence. An onset later in life generally suggests a medical condition such as multiple sclerosis. We want to assess for mood changes, how they function during hypomanic episodes, clinically significant distress or impairment in functioning, unpredictable mood changes, often regarded by others as temperamental, moody, unpredictable, inconsistent, unreliable, and no psychotic episodes, similar to major depressive disorder and bipolar disorder, but with less severity. Treatment is similar to both of these conditions, and they have an increased risk of developing bipolar, so they're commonly treated with medications. So when we're managing people who want to harm themselves and ultimately lead to death, we want to assume that anytime the client says they are having these feelings, that they are. We want to consider hospitalization and social resources. There is not enough evidence that the use of no harm or safety contracts can reduce the risk of this happening. It's not protective. So that's what we were talking about earlier. When I was reading that slide, I was like, well, actually, yeah. So those, like, you can't be like, promise me you won't, because that it just doesn't hold up. Protective factors include coping skills and social supports. And that is the end. Hope you guys enjoyed this lecture, and I'll see you next time. Bye. And good luck on your exam.